Hello, everybody. My name is Clare Pain. I'm a psychiatrist and I work at Mount Sinai Hospital in the psychological trauma program as a general psychiatrist. I also work with refugees and have the pleasure of working in Ethiopia from time to time as well. I'm delighted to be able to talk to you today about depression. And we're going to have a whirlwind buzz through in 20 minutes, and then there'll be 10 minutes for question time. I wanted to start with a sort of preventative approach, or how we optimize our own mental health and our patients' mental health. Being connected with other people and appreciated by other people is very much key to our well-being as herd mammals. Be physically active, learn new skills, whether that's a new language or a new recipe. Give back to others. Despite the fact we're all in the helping professions, there's still a need to give back, as with our patients. They too need to give back. And we need to be mindful, pay attention to the present moment. Depression is a major global public health problem. It's now the leading cause of disability in medium and high income countries, and it's designated to be the most prevalent disorder on the planet fairly soon. How do we recognize it? We recognize it with using the DSM-5 criteria. We need 5 out of 9 criteria. In criteria A, we need 5 out of 9 symptoms. It has to be, the patient has to have a depressed mood or a diminished interest or pleasure, or both, but you have to have one of those, and then 4 of the rest, 3 or 4 of the rest. Weight loss, insomnia, hypersomnia, psychomotor agitation or retardation, objectively identified, not just the subjective feeling of the patient, fatigue, and then the experience more cognitively of feeling worthless, guilty, poor concentration or indecisiveness, and recurrent thoughts of suicide. It's not the same. Depression over the globe is not the same everywhere. So when dealing with newcomers and refugees, it's as well to think as broadly as possible about how they express their depression. Don't just stick to the DSM-5. And it's important to be very aware that depression alone is quite uncommon in clinical medicine. The data we have in treatment is about fairly clean and pure depression. Most people have perhaps depression. They're struggling with substances. They're fighting with their spouse. They don't like to use public transport. It makes them anxious. There's a conglomerate of symptoms and problems for which they need probably more than a very 7-session CBT. That's a very good treatment. But don't be upset if they need rather more, and perhaps regular support from their family practitioner or nurse practitioner. We all need to practice trauma-informed care and to understand issues related to cultural competence, humility, and safety. But I think these are covered with the 2 other speakers today. When we think of mental illness and mortality, or depression and mortality, 800,000 people a year die from suicide. It's a leading cause of death in under 25s and seniors, and 9 out of 10 people who end their lives have a mental disorder. If a patient mentions they're suicidal, even if it's sort of a door-hand exit remark, take it seriously. Should you ask yes, it never makes things worse, and make sure you ask from passive to active plan to previous attempt. And the majority of mortality in depression is in combination with physical illness. So mental health conditions cause physical health conditions and are accompanied by it's a vicious cycle. Of course, people who have a physical health condition and a mental health condition have reduced help-seeking behaviors. They're under-detected and under-treated. They have poor adherence and a worse prognosis. These are chronic physical conditions, and up to 50% of a chronic physical illness will be accompanied by depression. The prevalence of depression in a chronic physical illness makes the physical illness much harder to manage or to treat and recover from. Baseline investigations for as you diagnose and start to think about treating depression will be CBC, TSH, vitamin B12, and EKG. Of note, we see anxiety and depression so commonly together, and it's perhaps heartening to know that there's robust evidence that depression and anxiety have a substantial overlap and are highly comorbid. They share similar risk factors, exhibit similar neurocognitive processes involving the limbic system, and respond to similar treatments. This is bringing coals to Newcastle. You would know more than I probably about the prevalence of subjective health complaints or medically unexplained symptoms. 30% or more of primary healthcare consultations are for medically unexplained symptoms. Perhaps they are sometimes considered by the patient a legitimate ticket in to see a primary healthcare person, and they tend to be particularly prevalent when the ongoing relationship with the primary care physician is lacking. So people who go to walk-in clinics tend to present more with medically unexplained symptoms. David Goldberg in England published widely on the idea that if you have a patient who has subjective health complaints and workups don't clarify any cause, any physical cause, and you think it is for a psychological depression, the idea, he said, was empathize with their symptoms, their physical symptoms, and then ask if stress can make them worse. And if the patient agrees, you've introduced the idea that a psychological approach may very well assist their symptoms. And in fact, these patients are well treated with the same treatments that depressed people benefit from, CBT, IPT, medications. Measurement-based care is now becoming a key part of our practices. I've just pitching for two instruments to incorporate into your practice, perhaps with every patient. This is the Patient Health Questionnaire 9. It has the 9 questions out of the DSM-5 and an extra question for function. And the scoring and the questionnaire is easily accessible on the web. How you incorporate paper and pencil questionnaires into your electronic medical records is a whole other question, which I'm not qualified to answer, but I recognize that that's the way we need to head. ACE screening, this is the Adverse Childhood Experience Questionnaire. I would pitch that every primary healthcare practitioner and every psychiatrist, perhaps all physicians, incorporate into their practice. In 1998, Folletti made this extraordinarily huge study of primary healthcare patients, and he found of the 10 adverse childhood experiences, abuse, emotional, physical, sexual, neglect, physical, emotional, household dysfunction, and not being raised by both biological parents. These were the questions, high in prevalence, to which, there they are again on the screening instrument, they get a score of 1. So if you've ever been physically abused, you get 1. Whether it's once or 50 times, the ACE score is 0 to 10. And it predicts not only here chronic depression, it's a massive predictor for the risk factors for serious illness and early death, also for really almost everything we're interested in as outcomes in health. So it's a first study, and there'd be many more of ACE, if you look up the ACE resources, but it's a first biopsychosocial, cultural, spiritual kind of evidence that you can't separate these things. Another example of how adverse childhood experiences affects all aspects of a person's life. The more you have, the worse it is. So here, there is some depression in people with no ACE scores, but in people with 4 or more ACE scores, it starts to get extremely high. Treatment. The treatment of depression, evidence-based treatment for depression, first-line medications are the SSRIs, pretty indistinguishable. Use what you're comfortable with. They do have some variations, but they're first line, as are the SNRIs, and bupropion and mirtazapine can be also first line medications as well. Second line TCAs rarely used, tricyclic antidepressants rarely used these days, very effective, but lethal if the patient takes the full month's dose of 200 milligrams of amitriptyline. Quetiapine and reversible MAOI, moclobemide, are also useful second-line drugs. Quite often we tend to combine drugs if at first you don't succeed. So you could choose an SSRI. If there are sexual side effects, you could switch to another SSRI, giving them the full treatment, trying to help them hang in for a full trial of treatment. But if side effects prevent, then you could switch to an SNRI. And sometimes if, for instance, there are sexual side effects, you may use, let's say, sertraline and a small amount of bupropion to offset the sexual side effects. I think we all get used to kind of playing a little bit with benefits and offsetting side effects. I would say if you have a bunch of medications you feel comfortable with to use them. Keep it simple, start low, start on a small dose, and go slowly. It usually, patients, I think, are more tolerant of medications if you go slowly, and it's less confusing. When you start a bunch of medications at the same time or go up too fast, you can sort of become confused around what in fact could work if it were used lower and increased more slowly. Most patients respond very fast to antidepressants in my experience, and they may not need the maximum dose. You go up to as high as is warranted, but I never do give the warning. I warn my patients of side effects, the commonest ones, but I don't warn them that it's going to take 2 weeks for the antidepressants to work. Too often I've had patients who let me know subsequently that the moment they took the first pill of their antidepressants, or within the first 2 days, they could feel themselves getting better. The psychological recommendations, evidence-based treatment for depression. And remember, these studies are done on a very clean depression. So for acute major depressive disorder, CBT, interpersonal therapy, and behavioral activation are extremely useful therapies. They're increasingly available, I think, although not really available enough, but they're on it's much better than it was for even 5 years ago. There are some good computer-based and telephone-delivered psychotherapies, particularly Bounce Back and Mind Balance. Mind Balance is an internet-based therapy that's available free to all Ontario citizens. Where feasible, combine medications and psychological treatments. The first-line psychological treatments for maintenance, depression that requires maintenance, is CBT and mindfulness-based cognitive therapy. But of course, we have to always bear in mind patient preference. My own pearls after 30 years in the job. The word depression can be quite obfuscating. As far as possible, try and find out what the patient actually feels. Are they unhappy? Are they miserable? Are they fed up? Are they angry? Are they terribly disappointed? Are they fighting? What's actually going on inside in their inner life? Depression is, as I say to the residents, a geographical description and can obscure really what the nature of the suffering is. People are unhappy for a reason. Take a good psychosocial history. Check for loss, either historic. Is this the first time they've been able to grieve for a beloved father who died during a busy period in life? Role transitions, even happy ones, a new partner, a new job, they can still cause a lot of stress, disputes and arguments. Those are good things to check because they so frequently do lead to symptoms of depression. And relate them, if you can, to the onset. Your mum died and then you started getting headaches and not being able to get up in the morning, etc. Try and relate the symptoms to the interpersonal problem. And right from the beginning, encourage people that the only way that they're going to secure their good health again is with your help and with the help of others. Reconnect to the people in their lives. If they're safe, if they're not safe, then reconnect to new and safer people in their life. Check for childhood abuse, as we discussed, childhood adverse events. Always check for substance abuse. We know the guidelines for alcohol. There are none for cannabis that I'm aware of. Check for domestic violence, historical or ongoing. The kinds of issues young people might have, eating disorders, psychotic disorders, and make a beeline for sleep. 5 consecutive hours is minimum a night. No more lying in bed than 10 hours in 24. Sleep hygiene, we all know about sleep hygiene. The plus is, do you know if your patient's sleeping on the couch with the TV on, with a baseball bat under the couch? So medications there's some choice around medications to promote sleep. Walking half an hour a day is essential, and we all need, including our patients, to learn how to manage our stress and how to relax. There are other therapies we can discuss if necessary, but they tend to be specialist oriented. There's some resources that I'll make sure are available. And I wanted to put in the last 30 seconds a slide from the apartheid time in South Africa, where there was no access by the Black majority. In that time, there were whites, coloreds, and Black people in the very appalling regime of apartheid that went on for decades. So people who were not able to access psychiatry, I think, can teach us a great deal about how to process trauma, depression in community, and in particular, using their body to communicate and express. And I think that we have a lot to learn from people who live in other cultures and who bring their cultures to us in Toronto. Thank you.